Hello. On behalf of the American Heart Association, I would like to welcome you to today's Implementation Science webinar, The ABCs of Lipoprotein A, What Researchers and Practitioners Need to Know. Before we begin, I'd like to quickly review how to use this platform for today's event. If you experience any technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please review the system requirements or contact the Zoom webinar helpline. Throughout today's presentation, you will have an opportunity to submit text questions for our presenter using the questions feature on your control panel. You may send in your questions at any time, and we will review the questions and have those available for our Q&A session as time allows. By email tomorrow, you will receive an invitation to complete our feedback survey. This presentation will also be recorded, and we will send an email to all registrants with the recording information within coming weeks. It is my pleasure to introduce our wonderful speaker for today, Dr. Marlis Koschinsky. Dr. Koschinsky is an internationally recognized expert on lipoprotein a. She is a professor of physiology and pharmacology at the University of Western Ontario and a scientist at Robarts Research Institute in London, Ontario. She holds a PhD in biochemistry from the University of British Columbia and completed her postdoctoral work at Gentech Incorporated in San Francisco, California, where her work with lipoprotein a began. Dr. Koschinsky has authored numerous definitive review articles, published over 180 reviewed articles, and has been involved in crafting scientific and consensus statements for the National Lipid Association, the American Heart Association's Council on ATVB, and the European Atherosclerotic Society. Dr. Koschinsky has been the recipient of many honors and awards in recognition of her research and leadership contributions, which include Fellow of Royal Society of Canada, American Heart Association, and the National Lipid Association, and the Canadian Academy of Health Sciences and American College of Cardiology, and she has been named to the Order of Ontario. Dr. Koschinsky, the floor is yours.
Thank you very much, David. That was wonderful. I just want to start with a disclaimer that the recommendations and opinions presented by our guest speakers may not represent the official position of the AHA, and the materials are for educational purposes only and are not an endorsement or instruction by the AHA or ASA. And here are my disclosures. So let's get started. First of all, I'd just like to tell you the learning objectives that I've developed for today. We're going to start by looking at the key features of LPA structure and how levels are determined in plasma. We are going to discuss the evidence for LPA as an independent and causal risk factor for disease. I want you to appreciate the mechanisms through which LPA may be pathogenic in the vasculature and be able to identify the key features of LPA production and removal from the circulation. I also hope that by the end of the presentation, you'll be familiar with approaches in development currently for LPA lowering and recognize how LPA can be used in the clinic. So we have a full agenda. So some of what I'm going to say certainly reflects the AHA scientific statement that I co-chaired with Dr. Gisette Reyes-Soffer. And this statement has been widely disseminated and is a really good primer on LPA. So I'm grateful to the American Heart Association for giving us the opportunity to develop this scientific statement. So for part one, let's start with the structure of LPA and how LPA levels are determined. So first of all, I just want to start by pointing out that this is basically showing lipoprotein densities, HDL, LDL, etc. And what you can see is that LPA is present in the larger density range of LDL, and it's shown with the arrow. And it's actually more dense than LDL owing to the presence of these black tails that you can see, which are the apoA moiety. And apoA is a very large protein, as you'll see in a moment. So that just puts you in some context. So this is a schematic of the structure of an LPA particle. And as you can see here, LPA contains an ApoB containing lipoprotein portion. Note that we're very careful not to say that it's LDL because it's actually metabolically distinct and there are some differences, but it does closely resemble LDL. To the LDL, what makes LPA unique is the presence of this apolipoprotein A or apo(a) moiety, which is covalently attached to ApoB 100. And what you can also see in this diagram is that the ApoA itself contains many of these structures that I've indicated here, these curious looking structures, and these are called kringles. And we're going to talk more about the organization of those kringles in just a moment. The other thing I want to point out is the presence of oxidized phospholipids, both on the ApoA itself, as well as on the lipid associated with the ApoB containing lipoprotein. So first of all, I'd like to point out when we're talking about the structure of ApoA, a little more of a deep dive into that ApoA is very similar to plasminogen, remarkably so in fact. So plasminogen is shown on the top. It contains 5 different kringle domains, labeled 1 to 5, followed by a protease domain, which can be activated to the active enzyme plasmin, which of course breaks down fibrin clots. ApoA, on the other hand, contains many copies of a particular sequence, Kringle 4 in plasminogen, that are very similar to the Kringle 4 sequence, with some amino acid changes to generate 10 types of Kringle 4 sequence in ApoA, numbered 1 to 10. This is followed by Kringle 5 and protease-like domains, very similar to plasminogen. However, note that the protease domain is inactive. Another thing I'd like you to note is that there's covalently attached oxidized phospholipid to the Kringle 4-10 domain of ApoA, and that domain also contains a strong lysine binding site, and that is required for the addition of that oxidized phospholipid. Kringle 4 types 5 to 8 each contain a weak lysine binding site, and I'm going to come back more to that when we talk about how LPA particles are assembled. The other thing I'd like to point out very importantly towards the amino terminus of ApoA, the Kringle 4 type 2 domain can be present in an identically repeated number of copies that vary from as few as 2 to more than 40. And this is one of the most distinguishing features of ApoA in that this is what gives rise to LPA isoform size heterogeneity, which is truly a hallmark of this lipoprotein. So what about LPA levels? Okay, so they vary a lot, as I'm sure most of you know. They vary widely in the population, way more than 100-fold, from less than 1 to over 100 mg per deciliter. And I've shown what that would be roughly in nanomoles per liter. So it's hugely variable. The other important thing that I want you to remember is that LPA levels are primarily genetically determined. So up to 90% of the observed variability arises from the LPA gene itself. And the extent to which that contributes does vary in different ethnic groups. But the bulk of this is from the inverse correlation that has been shown very clearly. It's a general inverse correlation, very strong, between ApoA isoform size and LPA levels. So the other thing I want you to keep in mind is that LPA levels are determined largely by production rather than catabolism of the particle. So just to make sure we're clear on the genetic basis for the bulk of the determination of LPA levels. So the LPA allele itself, the sequence that encodes Kringle 4 type 2, is present in different numbers of copies in the gene itself. Okay, just want to make that clear. LPA levels are comparatively resistant to conventional methods for LDL lowering, to the frustration of many people who are clinicians trying to deal with LPA levels that are really elevated in the clinic. So even though it looks somewhat like LDL, traditional ways to lower it, for example, lifestyle changes and statins. Statins are absolutely not effective for LPA lowering, and in fact, may slightly increase it. So that's a very interesting aspect of LPA and a challenge. So when we talk about elevated plasma LPA, certainly kind of what's been established in the literature is, say, greater than 30 to 50 mg per deciliter, which is roughly equivalent to greater than 75 to 125 nanomoles per liter. Elevated levels defined like that are an independent causal risk factor for a whole variety of different cardiovascular diseases. The greatest effect, however, of LPA on risk is for coronary heart disease and calcific aortic valve disease. Now, I just want to show you this map of the world with migration patterns shown in sort of the kind of upside down V's, the arrows. You don't have to worry about that. But what I want to emphasize here is two things. The first thing is that in the year 2022, the estimated prevalence of LPA greater than 100 to 125 nanomoles per liter is approximately 1.5 billion as of 2022, probably somewhat more now as the population is growing. That's one important thing. So this is not a rare disorder. Hyperlipoproteinemia is not rare. And what's also I want to point out is these kind of blue sort of curves on the very bottom of the screen. That just shows that in different countries, different parts of the world, there's a different isoform size distribution in the population. And what do we mean by that? Some populations, some ethnic groups have more small isoforms than large isoforms, or vice versa. And what I really want to emphasize here is that if you look at the African population, what you can see is that they have 30% or so of the population that's at risk, in other words, elevated levels of LPA. But notice that the distribution of isoform sizes is normal. It's not this bimodal, as you see for other ethnic groups. And this also goes for the distribution of LPA levels. And again, I'm not going to go through all of these, just to say that the skewed distribution of levels, it basically follows, the difference in distribution of isoform sizes, as you'd expect. Those are closely linked. But what's very important is that it's skewed in most populations, but much more normally distributed in the African population. So now I'm going to talk about LPA and risk for cardiovascular disease. So what's our evidence base for this? 2009 was a great year for LPA. A lot of great studies came out that year, and I'm just showing you really the very top line messages from 3 studies that came out all in that year. The first one on the left is a meta-analysis of prospective studies that demonstrated this very interesting curvy linear risk relationship between LPA levels and risk, beginning, as you can see, at approximately 30 mg per deciliter. In the middle panel, we had the results summarized here of the Mendelian randomization study. And in this, what was shown here, this is where we get the evidence base to say that LPA is a causal risk factor for coronary heart disease, because genetically elevated LPA levels, and how that was defined was by the sizes of the alleles encoding LPA. The genetically elevated LPA levels, increased risk corresponding to what was seen in plasma, so the levels that were measured in plasma. So it was a direct correlation between the gene and the levels associated with the gene and risk. On the right, we have the genome-wide association study by Clark and colleagues. Very interesting. 2 polymorphisms were identified, 2 variant alleles. And again, GWAS identified LPA as the strongest locus that was associated with CHD, and that the 2 variants, each variant increased risk and levels, and the 2 together basically acted synergistically to increase risk over fourfold when the two were present. So what about CAVD? Now, this has been fascinating. This is the most recent observation about the key role of LPA in disease. So calcific aortic disease, one of the earliest papers, I think the earliest paper that showed this, was done with GWAS, and it was published in 2013, and showed that this particular gene, it's a polymorphism. That was one of the ones I just showed you. I just didn't give it this name. But following that, you can see on the Manhattan plot shown on the right that particular the only significant, to put this simply, the only significant association between calcific aortic valve disease and risk was associated with that particular polymorphism, and the dashed line is the level of significance. So it's the only one, the only gene that was identified. So again, also Mendelian randomization further to that showed that genetically elevated LPA levels also were associated with incident aortic valve stenosis. The astronomer trial showed us something very interesting. And in the panel A, what you can see is that the increased rate of aortic stenosis progression was much higher in the top tertile of LPA levels than in tertiles 1 and 2. That's panel A. And in panel C, what you can also observe is lower event-free survival, where the event is defined as valve replacement. So lower event-free survival in the top tertile, again, of LPA concentrations. So very solid evidence. So I just want to show you this to show you that the initial observation from 2009 was really verified by looking at the UK Biobank. And what this was, this shows white individuals versus Black individuals. And what's seen here is that the relationship, again, between LPA levels and risk is linear for both of these populations. But the most important thing is that despite having a higher median level of LPA that's observed in Black individuals, it's really the levels of LPA that determine risk, not so much the nature of the LPA in the particular individual. So it's all about levels and not so much about, whether or not the isoform sizes are, differently distributed like they are in Black individuals. It's the levels that count. And that actually simplifies things because that really does eliminate the need for race-based cut points. So let's talk about biosynthesis and catabolism of LPA. And this is important when we talk about drug therapies that are under development. So this is an overview. And what I've shown here schematically is a hepatocyte, because that's where LPA is produced, and maybe where LPA is cleared, removed from the circulation. So let's start with the synthesis of LPA. So the ApoA, the gene encoding ApoA and the gene encoding ApoB are expressed in hepatocytes. They're both go through the secretory pathway, but they associate with each other non-covalently, using those weak lysine binding sites in Kringelford type 7 and 8 that I talked about right in the beginning. So that non-covalent complex then appears to be able to go through the secretory pathway, and then somehow either on the surface of the cells or in the circulation, a covalent association between ApoA and ApoB is formed. Okay, so then what about clearance? So you've got LPA in the circulation. How is it cleared? That's where the story becomes much more complicated in a way, because there have been a number of candidate receptors that have been identified, but there's not really one receptor that stands out as the receptor. And so it's not really clear that we've quite found the receptor, on hepatocytes. So just a little bit more about the assembly of LPA particles, and this is quite detailed, but I'll just take you through the top level. The first step, as I mentioned, was that non-covalent interaction that happens inside the cells, right in the endoplasmic reticulum when these proteins first encounter each other. And then the second step occurs outside the cells. We're not sure whether, again, it's the cell surface or maybe the space of this. But that is where the second step happens, where you get the disulfide bond formed between the Kringle-4 type 9 and a free cysteine in ApoB100. And that gives you what you can see on the bottom is the circulating LPA. So what about catabolism? I told you there were many possibilities, and I'm not going to spend too much time on this slide, just safe to say that if we focus on candidates that have been shown for the liver, I've just given you an idea of their structure. But again, we're largely looking at candidates that have been selected based on the similarity between LPA and LDL, the similarity between ApoA and plasminogen. So people have posited that the plasminogen receptor might be important. And then there's this asialoglycoprotein receptor that has been posited as potentially being important, because one thing I didn't tell you about ApoA, my bad, is that it's highly, highly glycosylated. So again, these are all sort of a candidate receptor approach. And my sort of work and my ongoing work really tries to get away from that and just take a non-biased approach to attempting to identify the receptor. So what about the pathogenicity of LPA? How does this work? Well, on the left, you can see immunohistochemistry analysis that was done with an ApoA antibody from a coronary artery section. The ApoA is immunostained. It's in brown color. This is from a 63-year-old male autopsy specimen. And what you can see is there's a tremendous accumulation of LPA in atherosclerotic lesions. Okay, there's a lot of brown here. This individual had high LPA levels. And it accumulates in the lesions to an extent that is proportional to its plasma concentrations. So that's one important thing to remember. The other is that LPA is selectively retained, that should say, pardon the typo, is selectively retained within the arterial wall relative to LDL, because ApoA is very good at interacting with cells and extracellular matrices that are present in this milieu inside the intima. Oops. For some reason, I was just temporarily frozen. So what about proposed mechanisms for pathogenicity? Well, we certainly know that LPA has the potential to be proatherosclerotic. And there's many mechanisms that we have identified, us and others over the years, that support that. So this is the inner circle here that we're talking about right now. Procalcific effects, certainly, there's lots of work been done on that, especially since the 2013 GWAS study that I showed you. And you can see here, this is a calcified aortic valve. And so the procalcific properties of LPA were very much evident. So that was the second sort of the trifecta. And the third was, could it be prothrombotic? And again, there were a number of mechanisms identified to suggest maybe yes, maybe no. And I'll come back to that more in just a moment. But what is interesting, and I'm not taking you obviously through all of these mechanisms that I've shown here, but what we learned was that all of these mechanisms here that mediate the proatherosclerotic effects and procalcific effects, all of these here are, by and large, really inflammatory responses. And so we really feel that the pathogenicity of LPA is highly dependent in those two contexts, as proatherosclerotic and procalcific, dictated by the fact that it's preferentially associated with oxidized phospholipid. LDL basically the oxidized phospholipid on LDL gets transferred very effectively to LPA in the circulation. LPA is the preferential carrier of these oxidized phospholipid species, and they are known to be highly pro-inflammatory. And I'm not going to spend much time on this. It's pretty detailed, but so just to show you, so this is an example of a necrotic core and a relatively advanced plaque. You can see the intima, medial layer, smooth muscle cells showing the contractile smooth muscle cells you can see in the medial layer as expected. You can see macrophages and dead macrophages associated more with the necrotic core and the lesion itself. ApoB staining is shown there. Now, this is an ApoB LDL specific antibody. So this is specific for LDL, and you can see that there. And what about something specific for ApoA? And what you can see there is, you can see just by inspection, they're not completely co-localized. In fact, they're co-localized not that well. And you can see in the ApoA, there's an awful lot of staining that's sort of more near the necrotic core, kind of looking like it's sort of facing the flowing blood, you know, and focused or concentrated, sorry, in the endothelial cell layer, which is really interesting. And then if you look at different oxidized specific oxidation-specific epitopes, if you're looking at MDA and MDA modified lipoproteins, MDA and oxidized epitopes on lipoproteins, what you can see is that the ApoA corresponds the best in terms of colocalization with something called EO6, which is an antibody that's specific for oxidized phospholipids. And that's where you see that LPA has the most correlation in terms of staining, not so much with the MDA modified adducts that are present on LDL. You can see that correlates better. Those correlate better. In fact, the oxidized and MDA modified epitopes correlate better with ApoB staining in panel D. So ApoA associates with OXPL epitopes, so oxidized phospholipid epitopes in vulnerable plaques. This is a vulnerable plaque. So what can I tell you about oxidized phospholipids? So let's just start, and I've said this already, the atherogenicity of LPA may be mediated in part, and we do believe that it is, by its association with pro-inflammatory oxidized phospholipids. Those are present on both the ApoA and the LDL-like component of LPA. In plasma, OXPL preferentially associates with LPA, as I've already said, and the major component of LPA that contains this oxidized phospholipid is ApoA itself, where it's covalently attached to the Kringle 4 type 10 domain, and that is dependent on the lysine binding, unique lysine binding properties of that Kringle. So what about OXPL on ApoA? What do we know about that in terms of pathogenic responses? Well, there's a whole list of things here that have been published starting in around 2010 and going right through until, you know, there's papers coming out on this all the time. So everything from promoting macrophage apoptosis through to promoting valve calcification, through pro-inflammatory roles played by the oxidized phospholipid, and also increased vascular endothelial cell glycolysis, facilitating, as you can see, inflammation and the invasion of leukocytes into the arterial wall. So lots of possibilities there. So I'm not going to spend any time on this at all because there's a very simple message I want to give you. So in terms of cells in the vasculature, whether it's smooth muscle cells, monocyte macrophages, endothelial cells, or valve interstitial cells, we believe that the oxidized phospholipid, primarily the oxidized phospholipid present on ApoA, but also there's some oxidized phospholipid on the LDL component of LPA2, as I told you. But it's very important, this oxidized phospholipid in its function as a signaling moiety. So there are receptors, we believe, some of which we've identified, some of which we haven't quite yet, but we do believe that there's signaling that occurs in all of these cell types in response to the oxidized phospholipid. There's signaling cascades that are triggered that result in these pro-inflammatory phenotypes in these various cells. So in summary, initially, why did we have 3 pieces in that circle diagram that I showed you in the first place? Well, the outer layer of that circle was pro-inflammatory. And as I explained, people initially thought, well, how can LPA, aortic valve stenosis is a different process. It's not exactly like atherosclerosis. How can LPA be contributing to both? And it's very easy. And I'll just point you to where we're kind of, we're looking at the arterial wall schematically. We're looking at the aortic valve leaflet schematically. And what you can see is what's in common here is inflammatory processes, whether it leads to what we see in terms of a developing lesion, foam cell formation, macrophage apoptosis, smooth muscle cell proliferation and migration, or, so in the context of atherosclerosis, or in the context of valve disease, osteogenic differentiation and calcification. So you can marry those two effects that LPA has in these two seemingly quite different disease states through understanding its primary role as an inflammatory mediator. So what about thrombosis? That's always a sticky one. So venous thrombosis, there were some experiments that, suggested a possible role of elevated LPA in venous thrombosis, but really powerful evidence, particularly from Mendelian randomization studies that were very large and very definitive, arguing against a role for venous thrombosis. So I don't think that venous thrombosis is a huge consequence of elevated LPA, if at all. However, arterial thrombosis, and you can imagine this, it's a bit more difficult to study this. So, but there are some suggestions from early work looking at imaging studies of arterial lesions. Also epidemiological studies that show that elevated LPA predicts resistance to endogenous fibrinolysis. And one that gets quite a lot of attention in terms of, really a bit of a proof of principle is the role of LPA in pediatric stroke, because in those patients, they really don't have a background of atherosclerosis. So these are largely thrombotic events that contribute to these strokes in children. But then there's arguments against, like, what about the fact that there's no effect of elevated LPA on response to thrombolytic therapy? There's arguments to be made for and against. But what's really coming into focus might be a possible role of LPA in platelet function. And we have some very exciting things going on in my lab in that regard right now. And also, too, another important observation that's kind of coming to the fore has been the Asprey study, and I'm not going to go into that in detail, but really suggesting that aspirin may have a beneficial effect in individuals with elevated LPA. And it was interesting because the Asprey study that I'm referring to was done in the primary prevention population. So we don't really know exactly. And a third possibility, I guess, that's also hard to study is what if it's when plaques rupture and a thrombus is formed that LPA contributes to the persistence of that thrombus. So there's some possibilities there. So what can I tell you a little bit more about what we've done to look at this? We did this back in 2019 when the Ionis compounds, the antisense oligonucleotide for developing LPA was in progress. And there were 2 versions of the compound at that time. You don't have to worry about that, but just know that the blue square is what we now call pelacarsen. And so the idea of this study was to look at ex vivo fibrinolysis in different patients, and patients that were undergoing either no treatment, the progenitor Ionis compound shown in red, or pelacarsen, shown in blue. Okay, so the first panel here on the left shows you that, yes, these compounds, particularly pelacarsen, effectively lowers LPA. Okay, that's great. Then, if you look at the bottom panel on the left, what you can see here is that there is no significant difference in ex vivo clot lysis in these three groups. So obviously, you know, there's the control and the two versions of the Ionis antisense oligonucleotides. So, and the correlation, in fact, before, you know, any treatment was done, we also looked at the lysis time as a function of LPA concentration and really didn't see anything there, no significance in terms of the coefficient of the correlation coefficient, sorry. And I'll just point out too, in the bottom, this is my work, and what you see is that ApoA on its own, just by itself, is very effective, in fact, when it comes to having effects on clot lysis time. So it takes longer for clots to lyse in the presence of ApoA. Now, having said that, LPA doesn't have that same effect. So again, a couple of caveats. These are static conditions, okay? So, you know, this is ex vivo, not within, you know, an animal or a human. So this is ex vivo. And it's also static. And what do I mean by that? These are performed in wells. They're not in the context of flowing blood. And we have some ideas that that might be actually an important parameter to take into consideration. Still doesn't rule out, though, an effect of LPA on thrombus formation at the level of platelet activation or the process of coagulation. And I'm just showing you these schematically. We've got fibrin in the middle, like a fulcrum. Fibrinogen contributes, of course, is key to the formation of fibrin, and then fibrin is degraded. Okay, so those are the two kind of parts of this. So could LPA promote fibrin formation? So in other words, can it promote clots? It could inhibit tissue factor. Actually, there's evidence, certainly in vitro, that it can inhibit tissue factor pathway inhibitor. It can increase platelet activation, and LPA can promote vulnerable plaques. Okay, so you might see a sort of a, you know, a series of mechanisms favoring fibrin formation and degradation. The evidence is not as good, but having said that, there is still a possibility that under some conditions that more closely mimic flowing blood, you might see an ability of LPA to inhibit plasminogen activation, or maybe change the structure of the fibrin clot to make it less susceptible to lysis. So what about pharmacological lowering of LPA? And again, I've shown you this diagram before, and I think you can intuit that clearance is probably not the best way right now. We wouldn't even know what we'd be targeting. So, and again, given that LPA, and I should have emphasized this more before, I apologize for that, but LPA levels are largely determined by production, okay? So not so much by catabolism. So synthesis seems to be a reasonable way to target. If you want to lower LPA, that would be a better bang for the buck than, you know, we don't really have a candidate for targeting catabolism anyway at this point in time. But having said that, investigational drugs are in the pipeline that lower LPA tremendously. Pelacarsen, as you know, is an antisense oligonucleotide, and olpasiran and zerlasiran are siRNAs. Okay, so they're affecting the production of ApoA and ApoA. They're interfering with the ability of the ApoA transcript to produce protein. And then muvalaplin is a new player. It's very interesting because this one is targeting the non-covalent association between ApoA and ApoB. So that's a different approach. So there's some things certainly in the pipeline that are interesting. So I'm not going to go over this in tremendous detail because I'm going to leave plenty of time for questions. But we've got pelacarsen, which is the Horizon trial. looking at pelacarsen. And this is the data for that trial, including the key inclusion criteria. So this is secondary prevention population. And olpasiran, similarly, is secondary prevention population, a little bit different inclusion criteria vis-a-vis cut point for inclusion. So these are ongoing, and as you can see, readouts are going to be coming soon. As soon as 2025 for the Horizon trial for pelacarsen, and the anticipated study end for olpasiran will be towards the end of 2026. So LPA apheresis, I'm just showing you, this was published in our 2022 scientific statement. LPA apheresis is an option. It is FDA approved. It lowers LPA very effectively. Of course, you get the rebound in 2 weeks, which you also would see with LDL. And of course, the apheresis will lower LDL as well, very effectively. So the conditions for FDA approval for using apheresis are shown here. And this approval came through in around, I want to say 2020. There's limited clinical trial data suggesting that LPA lowering lipoprotein apheresis reduces risk of events, but more definitive studies, I think, are always front of mind for people who are interested in this approach. As you can, think in your own minds about this, is that it's not going to be easy to set up a trial, to examine this, but certainly the lowering effect of LPA is significant in many individuals. So let me just finish off with LPA in clinical practice. So why would a clinician measure LPA? Well, again, it's common, relatively speaking. It's an independent risk factor, but it's not measured at this point in time in the majority of affected patients who have elevated LPA. They don't even know it because it's the measurement, the extent to which it's being measured is very low at this time. But that's the only way you would know if somebody has elevated LPA, is just to measure it with a blood test that's relatively inexpensive and quite simple. So awareness of the presence of elevated LPA is important, of course, because you know from what I've told you about the ability of the correlation between elevated LPA levels and risk, and again, could inform clinical decision-making even at this point regarding managing other manageable risk factors, okay? So cascade screening of family members with elevated LPA is also possible if you're identifying somebody, if you've measured it and the person's got elevated LPA. There may be some interest in looking at additional individuals in the family because of the co-dominant inheritance pattern. So how should one measure it? Well, this is like, this would be the ideal world. You'd want to measure it with an isoform sensitive assay with a 5-point calibrator in units of nanomoles per liter. Having said that, the assays are improving all the time. And I think the point I want to make is we would much prefer people to measure it. And if the measurement comes back in mgs per deciliter, the big thing I want to tell you is don't try to convert from mgs per deciliter to nanomoles per liter. That is not necessary. Use the values that you get. No conversion, because that's incredibly inaccurate. Also, we don't recommend correction of LDL cholesterol for LPA cholesterol because that simply is not reliably worked out at this point, that there's a way to do that that's accurate at this time. So what about the clinical implementation of LPA levels in risk assessment? So the current ACC-AHA guidelines recommend that risk assessment for primary prevention of ASCVD should begin with a 10-year risk estimation, and I know that most of you know this. And then there's risk groups. If the patient is borderline or intermediate, there's 10-year risk groups. And, that sort of certainly guides clinical decision-making. But if measured, the LPA level can be used as a risk enhancing factor, which is suggested by these guidelines, to use it that way. But we publish in our statement that you can actually calculate it yourself, because the data from Patel et al., which is the biobank data I showed you, suggests that the clinician can quite easily adjust the 10-year risk estimate for LPA using this formula. So you'd have your predicted 10-year risk times 1.11, which is directly from what was determined by the Patel paper for the UK Biobank data. So 1.11 to the power of the person's LPA level in nanomoles per liter divided by 50. That's a pretty simple calculation. So here's an example. 10-year risk of 10%, elevated LPA level to 50 nanomole per liter, and the updated predicted risk estimate would be 6.9%. So an additional risk burden of 6.9% based on the 10-year risk estimate for somebody with levels of LPA up to 50 nanomoles per liter. So that's actually very doable and not that hard. But again, you can't do anything if you don't measure LPA, right? So let me just quickly wrap up with my key messages. What are the hallmark features of LPA and how are LPA levels determined? So I told you that LPA contains a unique ApoA and ApoB containing lipoprotein. It's most similar in size and density to LDL, but remember, it's not LDL. It is metabolically distinct. Biosynthesis or production is the main driver of plasma LPA levels, and again, reflects the strong genetic determination because it's very dependent on isoform size, which arises at the level of the gene, the size of the gene. Okay, so elevated LPA is present in about 20% of the global population, as I showed you. It's causal and independent in terms of being a risk factor for cardiovascular diseases, particularly CAD and aortic valve disease. Oxidized phospholipid modification, as I showed you, contributes tremendously to the pathogenicity observed and associated with LPA when it's elevated. And we think that the OXPL accounts for many of these pro-inflammatory effects of LPA, not only in the artery wall, but in the aortic valve as well. LPA may also have prothrombotic properties. I don't think we can conclude one way or the other at this point. And I hope I've convinced you that LPA measurement can be useful in the clinic because you can improve CVD risk prediction for your patient and also better inform risk management. And elevated LPA, as I also mentioned, I think this is an important point, may prompt cascade screening of primary relatives. And at this point, I'm going to turn it over to questions and discussion. And thank you in advance for your attention.
Thank you, Dr. Koschinsky, for your presentation. We will now begin our Q&A session. As a reminder for our audience, please submit your questions for the presenter through the Q&A feature on your control panel. Dr. Koschinsky, our first question is it considered good practice to check Lp(a) on a patient with documented pre-existing cardiovascular disease that's currently taking a statin, aspirin, and antihypertensives? Since it would not necessarily change anything on what you are currently doing for this patient, is knowing the Lp(a) value important?
I think that, it just provides another piece of information that may help to decide how aggressively that, you may want to go after LDL. You really want to make sure that, you're just going to want to manage everything you can possibly manage. That's one thing. And the second thing is certainly, and especially in a secondary prevention population, you want to make sure that you're looking at the family through cascade screening to identify individuals who also may have high LPA that, again, could be perhaps managed more aggressively for the manageable risk factors. That's kind of how how we see it at this point in time. And again, there are drugs on the horizon, but I think the point that I always, and I like this because it's really a nice phrase to use. LPA is actionable now. We don't have to wait necessarily. We've got the tools, or I'm not a clinician, but the clinicians have the tools to be able to be really mindful of maximally managing risk to basically help to mitigate the overall risk in a patient, including that contributed by LPA, which right now we can't do anything about. But if you can really manage the manageables, then you're really helping that patient.
Thank you. And on that note about cascade screening that you mentioned, considering the genetic nature of Lp(a), if a family member or a parent with Lp(a) is tested and they have an elevated level, should younger adults or children also get their Lp(a) tested?
Well, that's a very good question. And again, I mean, I think there's some sense that, again, it's just the more about potential future risk. I think that's really where the conversations between the clinician and the patient and managing those relationships, it certainly from a practical standpoint, I think it's generally accepted that probably by age 10, if not even slightly earlier, LPA levels should be fairly well established. So, again, it's a matter of deciding, okay, what am I going to do with this information? Could it be valuable? Could it, help to promote lifestyle changes? If there's changes that, the practitioner feels are necessary for overall cardiovascular health. So I think in answer to that, again, I think these are really individual decisions that, people have to make, and, that clinicians have to feel comfortable talking about and managing with their patients.
Very good, thank you. Is Lp(a) testing considered a genetic test, and is it covered by insurance?
Well, I can't answer the insurance question because I'm Canadian. I know it's now covered here, as far as I know. We have a bit of a different coverage in different provinces, but from talking to my colleagues, I think generally the insurance covers it because it's now in the guidelines, in the Canadian guidelines, that it should be measured at least once in adults at the time of first lipid screening, so the first lipid panel. So yes, so I'm not sure. I can't comment about the insurance in vis-a-vis in different states in America. But and what was the second part of that question? Sorry, about the insurance.
Oh, they wanted to know if it was considered a genetic test.
No, it isn't, because we think about a genetic test as a polygenic risk score. So this is measuring the levels of a lipoprotein in plasma. So it's no more of a genetic test if you're just measuring the levels in plasma than measuring LDL is a genetic test. Now, having said that, the fact that the levels are largely genetically determined. And when I say codominant, it means that, so take myself as an example, my LPA level is directly, the result of the allele I got from my father and the allele I got from my mother. And together they're associated, those alleles with an LPA level. And so my LPA level is a combination of the two. And that's what we mean by codominant. But having said that, it's not really a genetic test in the truest sense.
Thank you for explaining that.
You're welcome.
Given the race ethnicity differences in Lp(a) distribution, do you think there are race ethnic differences in pathologic level of Lp(a)?
Differences in the level. doesn't appear to be so. So I showed data for the Black population. Also, the UK Biobank data has been used to analyze a similar type of analysis in South Asians. And also, I believe, I want to say, there was a third population too, Black South Asians, and I'm just sorry, I'm blanking on that. But anyway, so that's certainly a levels thing. Now, do we know 100% sure that the mechanism of pathogenicity is identical in different ethnic groups? We don't know that. We know that the level is important, but the way that LPA is manifesting itself, we don't really have the knowledge base to say that for certainty that that is the same, but we know that the risk is comparable. But how do we get to that risk? Is there slightly different mechanisms in terms of cellular responses? That remains an ongoing area of research.
Thank you. Is there a relationship between Lp(a) and hsCRP levels?
I don't know whether there's a relationship in the levels per se, but there isn't a functional relationship. So in other words, I don't think that there's any synergy between the two. And I know a paper just came out on this very, very recently. And I think that the mechanism of action of LPA is independent of CRP, of high sensitivity CRP. I don't think there's much of a correlation there at all, to be honest, based on the most recent data that I think I saw a couple of days ago.
Thank you. Our next question is, in regards to the formula that adjusts the 10-year risk, including an Lp(a) measurement, the formula that you showed on your slide includes Lp(a) in nanomoles per liters. Is there a formula that has the milligrams per deciliters?
Well, not that I'm aware of. That's what the units that were used to generate that data, right? So, we don't like to convert in between, but I'm sure such thing probably, can be fashioned that would be comparable. But I just don't want to say, because I don't want to encourage people to, use different measurements. That was from our 2022 scientific statement. And it was, the example that was shown in those units, but I can't see why, such a thing cannot be done with measurements. Such an equation can't be obtained using a different measurement, like using mg per deciliter. But it's just, that's not, been done, because the way that that was done was based on what was done in the UK Biobank, like what was, that, when you have a straight line, you can figure out like sort of like a slope, and you can, use that to be able to say, okay, then for every, X increase in levels, there's an X increase in risk, right? So again, I'm not discarding it, but I can't tell you right offhand, because as I say, I don't want to encourage interconversion, but that's a good question, and I'm sure it's possible.
Thank you so much. This has been a wonderful Q&A session, and we received a lot of excellent questions that we weren't able to get to.
Oh, that's too bad.
I want to thank everyone for submitting your questions. I'll turn it to David for some final thoughts.
Thank you, Dr. Koschinsky, for the great discussion today, and thank you to the audience again for the participation. When you exit this webinar, a feedback survey will pop up in your browser. Please take some time to answer that. You will also receive a follow-up email tomorrow with the survey, and the recording from today's webinar will be emailed to all registrants in the coming weeks. For patient education resources on Lp(a), please visit our website at heart.org/LPA. Thank you very much for attending today's webinar. We hope to see you at our future LPA series events. Have a nice day.